I have some disclosures, and I want to, in this 35-minute slot, talk about symptoms of polycystic liver disease, a very important aspect of polycystic kidney disease patients' lives for the most part in a subgroup of patients. And it's often overlooked is one of the take-home messages that I want to tell you about today and highlight that. And I want to refer you back to the KDIGO Consortium guidelines on a consensus document that was published a couple of years ago, all the leading experts internationally in PKD. And in those guidelines, they recommended at your initial evaluation of patients with this disease that you should have some form of cross-sectional imaging looking at the involvement of the liver in these patients. And many of the symptoms patients have may be due to the liver involvement. And now there are therapies and emerging therapies and interventions that can be used to target these symptoms directly, which I want to show you. And in the 21st century, we're in the era of precision medicine, and that integrates all of these things that you've heard today and will be coming with more therapies, tolvaptan and other medical therapies, and then procedures that Dr. Steinman mentioned and other procedures. And these are quickly evolving, and cross-sectional imaging is quickly evolving. And so we can learn a lot. And we now have quantitative analysis of our patients that's potentially available to you at your center. And many patients are expecting this now. And I think in our practice is quickly changing. The patients know from the information that's coming out with the treatments like tolvaptan that we can do quantitative analysis of their organ volume, and that's more mature now in the kidney, but we also do this in the liver disease, and I want to show you some examples and then discuss the major complications that we see. And so for most patients from the CRISP study, we know that most patients over their lives as they get older, and particularly in women, liver disease is a major manifestation for them. And over 80% of patients as they get older develop some liver cysts. Now that does not mean that they're all symptomatic, but it's something to be aware of. And when we get to patients with more severe aspects of the spectrum of polycystic liver disease, they begin to have manifestations of mass effects from the liver and or the kidneys. And these can be looked at in this study here from a Korean group, which I really like this study because it was using all of the clinical tools and the charts of the patients to look at what symptoms were associated with their polycystic kidney disease patients and patients with polycystic liver disease. And they looked at a log scale here of the organs, the kidney and liver, and then they looked at whether they had 2 or more pressure-related symptoms. And you can see here on this log scale that there's an exponential rise in these symptoms with 2 or more symptoms once the liver volume, height adjusted, gets over about 2,000 mils per minute. So that's mils per meter. So this is very important information for practice. And you know that patients get progressive kidney enlargement, and then some patients have severe polycystic liver disease, as shown in this postoperative surgical section. And this is the endpoint for this person with highly symptomatic disease with a resective surgery, which is reserved for just a few patients, but just to illustrate the fact that we need to quantitate their liver disease burden and look at that in all patients. Now, here's an example. I want to just move and talk about the other a rare genetic disease that was mentioned earlier and is important to discuss here because Dr. Harris mentioned, well, we see patients with severe polycystic liver disease. This is a coronal MRI showing, I'm outlining here for you the liver in this patient with highly symptomatic polycystic liver disease, who we would expect is having lots of mass effect symptoms. They probably have an enlarged spleen. They have clearly got cystic kidney disease. Often their kidneys are malrotated with this burden here. They're often symptomatic with back pain. And in this lady, usually it's a woman, who's had multiple pregnancies probably or has had estrogen exposure. This is a preventable things that you can talk with the patient about, removing these preventable factors. This patient's liver is in her pelvis. And so on physical examination, you can detect this. You do not need imaging. You can detect this on a good clinical examination. You may miss this. You may think it's the kidney. So again, cross-sectional imaging in the initial evaluation is important. Now, on the other hand, this is a patient with a rare disease, autosomal dominant polycystic liver disease. And I'm showing you this because it looks almost identical to this patient. And in addition to complicate factors, you see this patient has some kidney cysts, and this is not unusual. So this is a different genetic disorder. However, the physiology behind this disease is very much similar, and the approach to management is very similar for this patient. And so some patients may have this and walk in the kidney clinic. And so there are acute complications associated with single cysts and polycystic liver disease, and I just want to, for comprehensiveness, kind of list them out here to you. And as Dr. Steinman mentioned, cyst infection is a very important one, and I will highlight this because it's often missed and it's often difficult to diagnose, and it's often confused with a kidney infection, and it's often undertreated. Again, in 21st century, we have advanced imaging and techniques, molecular techniques that can help us to personalize the care. Now, a very important symptom that comes into the nephrology office, or you get the phone call from the emergency room, or your patient calls distraught, is acute, severe right upper quadrant pain, and that's usually due to a cyst hemorrhage. And this can be worse in that the cyst can rupture and they may develop hemoperitoneum, and sometimes in the liver and sometimes in the kidney that can develop into a more critical emergency requiring embolization or surgery. Now, very common are those periodic, moderately severe pain episodes associated with liver cyst rupture that last a few days. The patient may be moderately incapacitated, may have to take some time off work. They need some reassurance. Sometimes they cannot eat or drink, or they may need some IV fluids or hospitalization for pain management, or just a presentation to the emergency room, which is common, and then they get some form of cross-sectional imaging, for example, a CT, and you get a call from the mid-level provider or ER consultant wondering about this situation. And usually you can be reassured if there's some free fluid. I'll show you some examples. And sometimes the patient has to be hospitalized. More rare things are a torsion of a cyst, jaundice, and an important but rare complication of this disease highlighted in a recent paper I'll show you is ascending cholangitis, which is an important rare condition that can occur in PKD patients that can be very problematic to diagnose and has a completely different management pathway. Now, here's somebody that I had over the years that I want to show you. Again, we use a lot of MRI at our center because there's no radiation, it's available, it's high quality. Recommend you use the imaging at your center that you have most confidence in. Develop a relationship with your radiologist, as mentioned earlier, that you can call someone that has an interest in genitourinary radiology. And this patient here has had a ruptured liver cyst. This is actually a young nurse from the East Coast, and she's had a kidney transplant, and this is her on a good day. This is when she came to see me when she was feeling well. But then a few months or years later, she was seen in the emergency room, and you can see here she now has free fluid in the abdomen, and she presented with acute severe pain in her local emergency room. And so again, this caused great kind of confusion for several weeks, but she had severe pain. She needed to take some time off work. The imaging findings are somewhat confusing. They're never 100% certain. And the most likely thing that happened here was that she ruptured a cyst and has free fluid in her peritoneum from this. And this gradually got better with pain and supportive management. So these are quite common things to occur. Now here's another patient that I have that had polycystic liver disease, quite severe, as you can see here, diffuse disease all over the liver enlargement. And then this was her scan at one of her prior visits, but then again I got a call from the emergency room and she presented with acute severe pain, and this is a bleed into a cyst here. This is cyst hemorrhage, and you can see more dense material here with a fluid level in it in the patient supine. And then she's got a number of large cysts also in addition to this. So this patient had a hemorrhage into cysts. She was one of my patients that I was treating with octreotide therapy, a medical therapy that might benefit patients with highly symptomatic polycystic liver disease. So again, this patient needs support. There's confusion in the emergency room what this is. We nephrologists are familiar with these patients and can let the patient know sometimes these things can be anticipated and what to do. Now, again, the Hall study was highlighted as one of the largest cohort studies that was an interventional trial looking at the intensity of ACE-ARB inhibition in polycystic kidney disease patients, and also the long-term follow-up was there up to 8 years in these patients. And as a HALT investigator, I used information available from the cross-sectional imaging in 557 patients to describe overall the general features of polycystic liver disease in this cohort. And what I want to show you here on this graph here again is we have the height-adjusted liver volume. This kind of allows us to compare men and women. And you can see here on this graph that patients have their parenchymal liver volume here on the y-axis. So what we did was we measured the liver volume, we measured the liver cyst volume here, and we measured the parenchymal volume here. And what this shows is that there's a very wide distribution of polycystic liver disease. An example here of a patient with mild polycystic liver, you can see just a few cysts on their MRI, but already their caudate lobe is enlarged, and already even with this mild disease, they actually have parenchymal liver volume increase. Now, this is a log score, so this is very exponential. And so you see the cyst growth here, some people with very severe cyst disease, like this person here with more severe disease. And in fact, he had a liver volume of about 8 liters. And you can see that the liver volume goes up exponentially. So the people with highly symptomatic disease up here with very large livers, what happens is that there is a kind of a lowering of the liver volume, of the parenchymal liver volume in these patients, whereas it was exponential here because of all the crowding of cysts. Nonetheless, what we found in this study was that the parenchyma is also, the hepatocytes are also involved in this disease and are probably hypertrophied, and that was not known before. So the liver parenchymal volume also increases, but then in this very much the baseline group of patients at the baseline MRI in the study, that the parenchymal volume plateaued because of crowding of cysts. So now getting to those patients with more severe massive disease, again, they're not that uncommon. Patients presenting with abdominal fullness, a very common symptom, and then as more severe with loss of appetite. Reflux is very common, can be managed with proton pump inhibitors or other acid suppressive measures. Dyspnea is very common, early satiety, back pain, hernias is mentioned by others, and mild abnormalities in liver function is mentioned by Arlene. But these have to be watched. Sometimes there's something else going on. Now, people with massive disease that come to us for more definitive treatment options, they get desperate because they develop ascites. They can get compression of their hepatic vein, leading to outflow obstruction, which needs specific surgical intervention by the surgeon that is experienced in this type of surgery. Portal hypertension and bleeding from varices. Inferior vena cava compression, which can be a factor also that has to be taken into account before going ahead with a liver surgical intervention, because the inferior vena cava may need to be stented. You can get patients with jaundice, pleural effusions, and then displacement of the organs. These are very common. This is a very common problem, and some of our patients, we do hysterectomy simultaneously. We have done hysterectomy simultaneously with liver surgery. Constipation and alteration of bowel habit is very common. And again, eventually the patients lose mobility. We've had patients come in on total parenteral nutrition, and eventually they lose all muscle mass, failure to thrive, and have malnutrition and die. This Korean study again describes the symptoms. I don't know how to go back. There you can say the symptoms can be divided into gastrointestinal symptoms, and you can see here as the disease becomes more severe that these symptoms become more prominent. But generally, nephrologists don't really ask these questions. Pain is a very important factor, and dyspnea, as mentioned here, and these could progress with the liver disease severity. And as I mentioned earlier, it's the women in their third, fourth, fifth decades of deciles of life that have the more severe diseases manifested by organomegaly. And here again is showing the women here way out of range with severe disease. And so it's very important to counsel these women and their daughters to avoid extra exposure to estrogen, either premenopausal for contraception or postmenopausal if they're offered that, to prevent this. We did look at this in the Hall study and found that there was some also additive effect, of course, with multiple pregnancies in the women. Now, here again are the symptoms and complications. This very nice study, which collected all this data from Korea, and the hepatic complications can be anything from leg edema, where you should think IVC compression, ascites, hernias, infections, cyst rupture, as I mentioned, all of these things. And in a rare, very, very small group of patients, you can see hepatic fibrosis. Back pain is extremely common, but these patients can also have mechanical back pain, and I saw one on Thursday, a patient who came thinking that she had severe polycystic liver disease that needed intervention, but in fact, what I thought was going on was more a mechanical back pain issue, and she had a scoliosis. So we sent her to the spine clinic instead. Abdominal fullness, dyspnea, all of these things I mentioned, and then there's a very small but important group of patients that have intractable nausea and vomiting, and many patients, a very small number of patients taking analgesics, and some of these patients unfortunately become opiate dependent, have no quality of life, and we'll generally refer these patients when they have diffuse cystic disease and massive hepatomegaly for a liver transplant evaluation. Now, again, going back to this Korean study, more than one pressure-related complication with a height-adjusted liver volume of 2100. You, as nephrologists, can guesstimate the liver volume from those coronal sections I showed you if you have cross-sectional imaging. Many patients never see their imaging, is what I hear when they come to me. They are never shown their cross-sectional imaging. I think it's very important to show it to the patient. As they become larger, they have more symptoms. Now, what was interesting also in this study was that when you combine the liver and kidney volume, what you see here in this study is that there's these mainly women here where you have more severe disease. So there's a very nice scale showing the correlation of kidney and liver volume, and you see this mostly these women that have very severe disease. So to conclude this part of my talk, patients with moderate to severe polycystic liver disease exhibit a five-fold increased risk of these symptoms: mass symptoms, compression symptoms. Moderate to severe polycystic liver disease, at least in the Korean study, and probably we have an enrichment for those patients in our center because they come to us from all across the country. It's a common and clinically important problem, about 16% of patients with ADPKD. And the most important point I want to make from this is that these patients should be referred to specialized centers for further management, as the surgical expertise becomes very important in this group of patients to have a successful and safe outcome. And patients are scared. We are also involved in patient-reported outcomes and patient-centered care assessments. We're developing tools for patient-centered care right now. And very important to patients, they have a fear about what's going to be offered to them. And in particular, many patients with massive organomegaly, massive liver and kidney disease. And they worry because they've heard stories of people not coming back from surgery and mortality events. And they worry about what their surgeons are telling them, what they can offer. Now, I want to mention this important study from Oxford that came out last year to you, which was a cohort looking chart review, retrospective, very large numbers and very important information for nephrologists with an interest in PKD, I think, because what it showed was that Biliary tract disease, if you compare the people in that cohort, 23,000 PKD patients against 6 million hospital controls, that the hazard, that rate ratio was much higher, was significantly higher for biliary tract disease in this population. So don't forget to look for gallstones and common biliary tract disorders. Don't forget to look for cyst compression on the biliary tree. Common bile duct dilatation is very common, and it may be a benign finding, or it may have some significance in some people. Unfortunately, some patients, when they're seen by a gastroenterologist not familiar with disease, undergo ERCP and procedures because of this. We should be aware of this finding, and I'll go into its relevance in a minute. But very important are these findings of biliary tract, and as you know, diverticular disease and hernia are also commoner in this population. So this is important information. It was an epidemiologic study. It didn't go into detail about how to manage these patients. Now, I want to show you a couple of cases that we had. This lady here, as you can see, has very severe polycystic liver disease. You can't see the kidneys at all. Her whole entire abdomen is covered in cystic disease, which is diffuse and involves all lobes of her liver. Now, she was not feeling well, and just malaise. This could be going on for weeks or months typically. And what you can see here on the T1 enhancement of the MRI in the axial scan here, again, diffuse liver disease, large cysts, a large burden of disease, and this rim around this cyst here. So that, to the experienced eye, is very concerning for an infected liver cyst. Now, she may be going in and out of her doctor's office, or she may be going in and out to the emergency room, but she came to our center because she was from our region, and she has polycystic kidney disease, as you can see here. This high quality imaging permitted us to study this patient's problem in more detail, and we obtained a SPECT CT with indium labeled white blood cell scan, a nuclear scan. This blurry image here is what this is, and you can see her liver here, and that's her spleen with the white cell uptake. And this allows us to pinpoint that the problem is in this area and correlates with this and probably a couple of cysts in this patient's left lobe of the liver. Well, in fact, while all of this was going on, she decompensated, she became bacteremic and went into septic shock and was in the hospital, rushed to emergency liver surgery, and the treatment for her in the end was a left resection here, as shown in this post-operative specimen. And she's done very well and comes back to see me. So I want to show you an example of a dramatic result of a patient with an infected liver cyst. I want to show you the imaging and the resolution that we can get nowadays. I want to show you the types of findings that can help us. I want to mention the commonest organisms are typically E. coli and Klebsiella. There's some more work coming out on that from some other centers. Depending on your microbiology support, you may not have good bacteriology, but blood cultures are very helpful. And you can monitor the C-reactive protein. You can use the C-reactive protein and criteria of fever greater than 38 and consider in those patients infected liver cyst or pyelonephritis or an infected kidney cyst in those patients. There's a couple of papers that I don't have time to go into that go into that in more detail. And you can see advanced nuclear imaging helps us pinpoint the problem in this patient. And ultimately, she required a surgical intervention. I'm going to show you another case. This is a young woman with mild polycystic liver disease. And again, in the 21st century, you can get PET scans. And PET scans can be used to source infections and tumors. And you can see here, she's got something going on in her liver. It's not very enlarged, however, but you see here there's a very high uptake of glucose. Now, the kidneys normally excrete glucose. I don't find this scan very helpful for infected kidney cysts so much, and it's excreted in the bladder. But there's something going on here which helped us pinpoint what was happening and allowed us to go in and drain her cyst. And this, in addition to blood culture findings and then followed by treatment, allowed us to manage this patient. And she needed the cyst drained and some fluid around the cyst drained, and then several weeks of antibiotics. And subsequently, her problem was combated with antibiotics. But this can be a very challenging case. Typically, they're gram-negative bacteremia. They may be partially treated with antibiotics. They come and you may not have the benefit of culture diagnostics, and you can rely somewhat on imaging, but in this case, again, we needed to drain her cyst. We have people that have expertise in that in our radiology department. She had to have 2 cysts drained. There's the air in the cyst and the contrast going in and the catheter. And then eventually this patient did well. However, long term, she did not feel well, and we decided to treat her with rotating oral antibiotics. And since then, she has done very well. We will consider using those for up to 6 months or longer. So now, polycystic liver disease, we really need some kind of medical therapy for these patients. Patients aren't ready to have surgical interventions and major surgeries that they are. Really, there's an unmet need here for medical therapies. And we know that central to the molecular pathways involved in this disease are cyclic AMP, and this has also been proven by our group and other centers to be centrally involved in the pathogenesis of polycystic liver disease also. Now, somatostatin analogues, in particular, we have a lot of experience now with octreotide long-acting injectable therapies, but other groups in Europe, and it's available in the United States for treatment, use lanreotide. And these drugs have been shown in several small studies, which I'll summarize in the next slide, to improve the quality of life in symptomatic polycystic liver disease. And they retarded decline in kidney function in ADPKD in some small studies. These studies are summarized here, and there's more to come on this. The pivotal clinical trial for somatostatin analogues in arresting and slowing GFR decline is completed, called DPAC in Europe, and is under review and soon to be published, and the oral abstract was published at the European meeting this spring in Copenhagen. I'll mention some of the results. But as I show you here on the diagram from our colleagues, the pathway is well worked out, that somatostatin pathway on somatostatin receptors in the kidney to the GI coupled proteins influences cyclic AMP. But not only that, there are other growth factor pathways involved in that can be targeted in medical therapies potentially for this disease. Unfortunately, there hasn't been any effectiveness in patients of using tolvaptan for the liver disease, and it's not used for that at the moment. I'll show you the animal data. So here is a summary, a high-level summary of the somatostatin analog therapies, which are injectable therapies at the moment. There may be oral compounds coming, but there are a number of studies now that don't meet the FDA requirement for pivotal randomized controlled clinical trials because they're small. These patients are rare with severe disease, but they've been done across multiple centers, and the evidence appears quite compelling for the use of octreotide and lanreotide that target the SSTR2 and 3 receptors that are expressed in the kidney and liver. And we've done a trial with more potent and pan-receptor agent analog, pasireotide. And just want to show you some of the results from that. And again, I want to mention the pivotal clinical trial from Mayo with over 300 PKD patients. I expect that we're going to have some secondary analysis of this drug in the liver disease, but we have a good deal of information from the Italian group, our US center, and the Dutch group, indicating that you can expect something somewhere between about 4 and 5% reduction in liver volume per annum, annualized liver reduction in growth in these patients receiving these therapies. Now, these therapies, this drug is not FDA approved for this indication. However, the drug is widely available. It's coming off patent, or has come off patent. It costs about $7,000 to $11,000 a month injectable. I can get this approved for patients. We follow these patients annually, and it has a role to play in patients with moderate disease that do not want surgery or declining surgery in clinical practice in patients that are highly symptomatic with this disease. It's not needed in patients with mild disease, and generally we don't really need to have this treatment continued in postmenopausal women, since their livers tend not to grow so much postmenopausally. So there's a good deal of evidence for this drug. Just to show you some of the original data, a very small study from Italy looking at its effect on total kidney volume change was significant in a crossover 6-month study by Dr. Ruganetti in Bergamo, Italy. A post hoc analysis showed that the liver volume was also significantly impacted in that tiny study. This was followed by our trial and the Dutch trial that I mentioned, again showing positive effects in reducing the growth of liver volume, and this was clinically impactful. It reduced the decline in quality of life in those patients using a blunt questionnaire called SF36 that's used across many trials. And you can also see that there was some signal in that it did have some impact on kidney volume as well, but GFR continued to decline in that study. So now I want to switch. I didn't go into detail on the liver data, but showed you the results from the Dutch trial. But I want to mention this early report from the DPAC-1 study that mentioned there was a problem in their cohort looking at patients that were a very large study, and they were looking at these patients receiving lanreotide and its safety, and they were comparing it to standard of care here. And what they found in this early analysis, interim analysis, which they published quickly, was that there was more cyst infections in the liver in the patients treated with lanreotide on this clinical trial. However, they did have to discontinue the drug in 7 patients, of whom there was 8 infections. So this was a worry. We have not seen this degree of problem in our patients, in our studies, in our trials and open label extension studies. And one of the risk factors for infected liver cyst in patients receiving these monthly injections is that they might have had a previous cyst infection. And as I mentioned earlier, that can be difficult to identify. So our most recent drug trial was with pasireotide, the pan-somatostatin analog. We were hopeful that this drug might have even more potent effects on the liver and kidney. However, the results of that trial were positive. However, there's a good degree of problems with hyperglycemia and diabetes with this drug. So we're continuing, the patients coming off this trial, we're continuing them on octreotide injectable monthly therapy. And so we can prescribe that. It can be locally prescribed to a patient in California. They go to their local infusion center, or somebody can inject it to them locally. There's some issues with how to prescribe that drug that I can discuss offline, but it's very widely tolerated, and we have good safety with that drug. We haven't had major problems. This was the results of the pasireotide study. Again, the study was positive. There was a reduction over 1 year in patients with highly symptomatic polycystic liver disease that did not want surgery and that had highly symptomatic disease in slowing down growth compared with the placebo growth, and this was highly significant. As you can see, however, some patients continue to grow. They seem to be resistant to this treatment. And I think my personal opinion is these patients have more advanced disease. When they went into the trial, they're growing exponentially, and we're blunting their growth, but they continue to grow. And hence, some of our patients during this 3-year trial, we've now completed open label extension, did drop out, and some of them did have liver resection surgery. And so I want to discuss with you in the latter part of my talk sort of examples of patients that do well with liver resection or liver transplant. And again, I mentioned the problem with this drug was the diabetes and hyperglycemia, and this has countered the quality of life improvement for these patients on the injectable therapy monthly, and so blunted, and we didn't see an improvement in quality of life on this drug, whereas we did with the octreotide injections. And patients come in and they don't want to stop octreotide, so feel very confident about the drug and its role in this disease for some patients. So also, we published these information about the patients that were in our original octreotide study. There was 13 that went out a further 2 years on drug, and we again continued to experience that there was a continued reduction in arresting and reducing liver volume growth in those patients on long-term octreotide. Some patients, most patients from year 2 to the beginning of their open label extension, on average about 8 months, were off the drug because it's very expensive. We couldn't get it for them. The drug company came in again, Novartis came in and gave us the drug off label. But you can see here their liver volume started to grow again. So long term, we think there's a role for this treatment. Stopping the treatment, the patients tend to regrow. And so questions that one could raise might be, what is the right dose? Who should be continued on this? I think you have to make those decisions on a case-by-case basis. We tend to follow these patients. we have them come back and we monitor their organ volume on an annual basis with MRI because of the lack of radiation. Same findings were seen in the Aladdin group from Italy, Dr. Ramuzzi's group, that they found positive effects with this drug over a slower long-term effect was seen. So again, they continue to respond in terms of the liver volume. So at this part of my talk, I'm trying to summarize what we know about the role of the somatostatin analogues for you. The trial that we did with the pasireotide or SOM230 versus placebo in a randomized controlled trial decreased the liver volume growth and kidney volume growth, but was no more effective than octreotide. And so we tend to favor continuing our patients that are not on trial on clinical management with octreotide if they're symptomatic with polycystic liver disease and aren't interested in surgery. There was problems with hyperglycemia and diabetes. So they're promising, they're well tolerated. DPAC, the Dutch study, found no difference in the impact between lanreotide and the placebo on rate of kidney function decline. And my talk is centered on liver disease, and I'm not going into this because the paper is not out yet. As mentioned, only it's been published in abstract form. But I know there'll be broad interest in other drug therapies in polycystic kidney disease. We continue to work on these drugs in development and their maturing role in this disease. There is a possible risk of hepatic cyst infection, and we have completed and submitted the results for our open label extension study for another 2 years on the pasireotide SOM230. And again, it continues to show efficacy in those patients, in that subset of patients that benefit from being on a somatostatin analog therapy in the long term. Now I want to go back and discuss where we are in this field with other therapies in this field, because we talked about cyclic AMP again being central and other small molecules and growth factors that could be targeted, and what evidence there is that's been published so far. So we think, like many treatments, like cancer drugs, like the field of cancer that's rapidly changing, we see that there could be different signaling pathways targeted. And this could be with targeting cyclic AMP or cell proliferation or autophagy. But the somatostatin analogues work on the cyclic AMP, so do the vasopressin antagonists. We also have published work, and others are studying, and there's a role for other anti-cancer therapies like histone deacetylase inhibitors. We've shown in animal models that these are quite effective, and there are other drugs that I don't have time to mention, but there are many other potential both druggable targets in PKD, and now there's intense interest in the pharmaceutical world, our partners in this area. And so I want to mention an important negative study about mTOR inhibitors, because mTOR inhibitors, as we nephrologists know, are very important druggable immune pathway and growth pathway. And the mTOR inhibitors are FDA approved with everolimus for tuberous sclerosis, and many of you may have patients with TSC and are on everolimus, which isn't an easy drug to deal with. But in this disease, it was not effective, at least in the small study from the Dutch group. This drug was not effective in addition to octreotide. So that's open and closed, that there won't be any more work on this. And there was the other studies in the New England Journal with this drug looking at it in more advanced ADPKD patients, and the studies were negative. So now I want to just summarize some emerging data looking at pasireotide tolvaptan, a paper from Vicente and Katerina Hopp and our group at Mayo, looking at the RCRC mouse, looking at control, untreated, tolvaptan treated, pasireotide treated, and then both therapies given to the mouse. And there seemed to be an additional benefit in liver and kidney. The kidney is shown here, but also the liver in double blockade in these patients. So this is very interesting because there again was confirmed that in the animal model that there was hepatic hypertrophy, mirroring what we showed you in the Hall study data, and that this could be corrected by the pasireotide treatment. So this is open for further evaluation. Furthermore, a Japanese group that have been well established in this field used their rat model and looked at double somatostatin blockade with both pasireotide and octreotide, and found that there was some added benefit to using the combination of the two somatostatin analogues as shown here in kidney, cyst, and I can't read what that is, BUN. So there was some added benefit to double therapy. And again, what's interesting to me working in this area is that they were able to blunt and drop the IGF, a growth factor level in those patients more intensely with the double therapy. So this is very interesting and a potential biomarker of the disease, a readout of the disease, and druggable target and blockade using these double therapies. So I think there still is interest in this area, and the role of combination therapies is still open for further evaluation. Now I want to finalize in the last part of my talk a couple of cases, again, to kind of just cover fairly common issues that occur in patients and focus your attention on options for patients. So this man here, he actually has ADPKD, he doesn't have kidney cysts, but he has a very large liver, and you can see here he has very dominant cyst here, and it's raising his diaphragm, he's probably short of breath, and he's having some mass effects. And so he was one of the first patients that we did a foam sclerotherapy procedure on at our center, and this is a procedure that was pioneered initially at the University of Toronto, and some data published for its role in sclerotherapy of kidney cysts, mainly at that center, using a sclerosant. So those of you that have varicose veins, if you go to the varicose vein clinic, you may be offered vein sclerotherapy. Well, the sclerotherapy, it's a kind of a glue that they inject in. So what we do is our interventional vascular radiologist sucks out the fluid here. There was 2.7 liters in that cyst and 350 in the other one. So they suck that out and then they inject the sclerosant. Now, we haven't fully perfected this yet, but we've done about 30 patients, and I'll show you some preliminary results. And the patients get good symptomatic relief. Now, sclerotherapy was mentioned earlier. We don't put things in for diagnostic purposes. We suck fluid out in our center, and then we try the sclerosant to make it stick down and have a more durable response with the kind of glue effect of this injectable therapy. All of this requires a learning curve by our radiologists. They're anxious about what dose to be used and repurposing this drug in this type of procedure, but we've had a very good safety record so far, and it's a way to alleviate patients with mass effect symptoms with large dominant cysts. And so it's interesting what we've found. This is a very small analysis of the liver volume so far. It does reduce. We have developed a quality of life questionnaire specific for polycystic liver disease, and you can see there's a very big drop in the symptom score following this at 6 months. So patients their symptoms are improving with these types of interventions, and this is something that could be done at other centers. And we've had no major adverse events. What we don't know, I think, is how much dose of this sclerotherapy we can use. We're experiencing patients getting them done and then coming back a few weeks or months later and having round 2 of this because they feel good with the initial result and want more to reduce their mass symptoms. Now, lastly, just to discuss the role of liver surgery, and many patients are referred to us for that because we have a very strong surgical team in hepatobiliary surgery. And this is a patient here of mine that had a right hepatectomy. That's her stomach there. This is the pre, and this is the post, and you can see her left lobe is massively enlarged, her right lobe is down in her pelvis, and she did very well, and her left lobe is moved over to the right side, and now you can see her stomach and her early satiety and mass symptoms will have greatly improved. This is a procedure that we do quite often. We now have 3 liver surgeons working on these patients, and so we're seeing a lot more patients coming for this intervention. And this study from Fouad and our group, published in a surgical journal, shows you the average age of patients that we've in our second generation of this paper from the original paper that was published. Over 180 patients, mostly in their 4th decade. We take patients in their 30s that come in with this and have this done. Very low mortality. Need an experienced surgeon. We have special surgical floor surgical team for this. And you need to have 2 or more contiguous liver segments relatively free of polycystic liver disease. We do see patients that have been denied surgery at other medical centers by liver surgeons that do not offer this or don't like this type of surgery. We've had very good results. As you can see here, the average patients that we see. And what we want to show you here in this graph is liver volumes and time from surgery. And the bottom line take-home message from this is that we see a 63% reduction in liver volume. So that long-term provides very durable outcomes for these patients. And there's a small group of patients that grow even after surgery, mostly young premenopausal women that continue to grow, and I may put them back on octreotide if they're having subjective symptoms from that. So this is a very durable response. It's a big surgery. Patients usually with us for about a week. They may go home with a drain. They generally do well. We've had very low mortality. We reserve this for patients that are highly symptomatic. We see a 60% reduction in organ volume. A subset of patients continue to grow and may benefit from octreotide. It all hinges around having a very good colleague that we work with directly, see him all the time, refer him cases, anticipate which patients might be suitable for this and which ones might not. And he is always in town when the patient is undergoing the surgery. And we have 2 new surgeons that are also gaining skills and competency in this with his backup. The options, in summary, for surgeries, there are different things. So now we've originally did alcohol sclerosis. Now we're doing almost exclusively foam sclerotherapy, aspiration sclerotherapy. We can do a diagnostic aspiration, but generally we're doing a foam procedure after the aspiration. Some patients benefit from laparoscopic fenestration. Mostly we're doing resection and less laparoscopic fenestration. Patients have a tough few months usually after fenestration, at least in my experience. But some patients will benefit at the time of liver resection from fenestration of all these cysts or laparoscopic fenestration alone in large dominant cysts in the outside of the liver. And then we reserve liver transplantation for patients with severe diffuse disease. And mostly we do this with deceased donors. However, we've done 1 or 2 patients with a living donor liver transplant in selected cases, but that's not a routine approach yet. So this is a very viable option. Liver transplant in patients, especially patients that are highly symptomatic, debilitated, disabled, and often opiate dependent. It is very difficult. They have to get a UNOS exemption to get a liver transplant because they are competing with your patients in the intensive care unit that are in liver failure on liver dialysis. So it's very difficult to get them this exemption. So you need a special hepatologist that's familiar with this entity to get the paperwork approved by UNOS. And each region is different for those. And I've had patients denied. There has to be a certain list of criteria. And as you know, organ availability for liver varies around the country. This has reached national media attention, as you know, people dying on the liver transplant list. So in summary, there's many challenges in polycystic liver disease. However, I feel upbeat about there are many treatment options now. Our imaging is much better. We have colleagues with skills that can assist us in managing these patients. We need subspecialty input from various areas. And we do have expanding treatment options for these patients, including somatostatin analogues. Although they're not FDA approved, there is good evidence for their basis, and we can get these drugs approved on a case-by-case basis and manage these patients with you. Need a reliable surgical team for these major liver surgeries. The interventional radiologists are getting bolder. They're more confident with using these sclerotherapies, at least in our center. Quantitative imaging, we can monitor those patients longitudinally and the effects of our interventions. And we've been developing, and others have been developing, patient-reported outcome tools that are specific to this disease because general quality of life questionnaires just don't do it justice. And when you're working with a partner in pharma, we need these tools so that because the FDA will accept patient-reported outcomes, they're very important. And in the cancer world, a drug will get FDA approved very quickly with that type of information. We need to learn from that. I want to acknowledge the people that we work with. It is a multidisciplinary team at our center and the PKD Translational Center where we get a lot of valuable information with our genetics and imaging and quantitative imaging, and we can quickly measure liver volumes. Thank you for your attention, and hope you enjoy lunch.